Cyanosis is a common clinical finding in infants at birth and beyond. Neonatal cyanosis, specifically central cyanosis, can be associated with serious and potentially life-threatening diseases due to cardiac, metabolic, neurological, infectious, and parenchymal and non-parenchymal pulmonary disorders. Good day to all and welcome to this panel discussion on cyanosis in the newborn. These are my objectives for this session. Cyanosis, from the Greek kunios, meaning dark blue, refers to the bluish discoloration of the skin, nail beds, or mucous membranes. If cyanosis is limited to the extremities, it is referred to as acrocyanosis or peripheral cyanosis. This is relatively common in newborns and is generally a physiologic finding due to the large arteriovenous oxygen difference that results during slow flow through peripheral capillary beds. Peripheral cyanosis typically affects the distal extremities, as seen here in the hands and feet, and sometimes the periorbital or circumoral areas, as shown in the last photo. In this case, careful examination will reveal a pink tongue and oral mucosa. In contrast to acrocyanosis, central cyanosis is present throughout the body and is evident in the mucous membranes and tongue. Central cyanosis in any newborn requires immediate evaluation. Peripheral cyanosis occurs due to increased oxygen extraction by the tissues, while central cyanosis is caused by systemic arterial oxygen desaturation. Again, persistent central cyanosis is always abnormal and should be evaluated and treated promptly. While oxygenated hemoglobin is bright red, reduced hemoglobin is dark blue or purple in color and is what produces the dusky or blue color of the skin and mucous membranes. An important concept is that cyanosis is dependent upon the absolute concentration of reduced hemoglobin, rather than on the oxygen saturation or the ratio of reduced hemoglobin to oxyhemoglobin. With careful observation, cyanosis may become apparent when the deoxygenated hemoglobin content is as little as 3 grams per deciliter. As clinicians, we must understand factors that affect the detection of cyanosis in the newborn, which include hemoglobin concentration, fetal hemoglobin, and other physiologic conditions that affect the oxygen dissociation curve, and pigmentation of the skin. Cyanosis is visually perceptible when reduced hemoglobin exceeds 3 grams per deciliter, which generally corresponds to an oxygen saturation level below 85% in a neonate with a hemoglobin concentration of 15 grams per deciliter. In a patient with hemoglobin of 20 grams per liter, cyanosis, which is 3 grams per deciliter of reduced hemoglobin, is detected when the oxygen saturation is 86%. In a patient with a hemoglobin of 9 grams per deciliter, cyanosis is observed when the O2 sats are 67%. Therefore, infants with polycythemia may exhibit cyanosis at relatively high arterial saturations, while it is more difficult to discern cyanosis in a severely anemic infant unless the oxygen saturation is extremely low. In general, the relatively high hemoglobin of the normal infant tends to facilitate the recognition of cyanosis. Fetal hemoglobin, the predominant form of hemoglobin in newborn erythrocytes, binds oxygen more avidly than adult hemoglobin, which helps in fetal uptake of oxygen from the placenta but results in less oxygen delivery to the tissues. The oxygen dissociation curve for fetal versus adult hemoglobin is shifted to the left, so that for a given level of arterial oxygen tension, PaO2, the arterial oxygen saturation, SaO2, is higher in newborns than older infants or adults. So, for a given level of O2 saturation, there is lower PaO2 value in newborns compared with older patients. For example, when O2 saturations are 50%, PaO2 is 27 millimeters mercury in older patients and lower at 20 millimeters mercury in newborns. If O2 sats are 80%, PaO2 is 45 millimeters mercury in older patients and 35 millimeters mercury in newborns. As a result, cyanosis is detected at a lower PaO2 in newborns who have predominantly fetal hemoglobin compared with older patients. This observation should prompt the measurement of PaO2 with an arterial blood gas when evaluating a cyanotic newborn, as the PaO2 provides more complete data than just O2 saturations. Other physiologic factors common in sick newborns affect the oxygen dissociation curve. Factors that increase the affinity of hemoglobin for oxygen include alkalosis, hyperventilation with low PCO2, cold temperature, and low levels of 2,3-diphosphoglycerate or DPG. In these conditions, the oxygen dissociation curve is shifted to the left, which decreases the concentration of reduced hemoglobin at a given PaO2 and lowers the PaO2 at which cyanosis first appears. In contrast, acidosis, fever, or increased concentration of adult hemoglobin shifts the curve to the right, thereby lowering oxygen affinity. As a result, at a given PaO2, these conditions increase oxygen delivery to the tissues, resulting in a greater concentration of reduced hemoglobin, and promote the appearance of cyanosis at a higher PaO2. Cyanosis is often less apparent in patients with darker skin pigmentation. For this reason, examination should include the nail beds, tongue, and mucous membranes, which are less affected by pigmentation. Using an ABC algorithm of evaluation, ABC standing for airway, breathing, and circulation, will allow the clinician to systematically consider the most common causes of cyanosis at birth and in the extended neonatal period. A for airway includes upper and lower airway disease as listed here. Most airway abnormalities will present shortly after birth. Cyanosis due to these conditions is generally due to alveolar hypoventilation secondary to airway obstruction. B for breathing covers lung disease and conditions with hypoventilation. Pulmonary disease resulting in ventilation-perfusion mismatch is the most common cause of neonatal cyanosis. Newborn infants who present with cyanosis from lung disease will almost always have some degree of respiratory distress. Neurologic dysfunction, such as hypoxic ischemic encephalopathy, intracranial hemorrhage, seizures, and metabolic disorders such as severe hypoglycemia may cause hypoventilation and apnea, resulting in hypoxemia and cyanosis. C for circulation implicates cardiac and circulatory causes. Both high and low levels of hemoglobin may lead to cyanosis, although for different reasons. Polycythemia can cause cyanosis by two mechanisms. Polycythemic infants may appear cyanotic with a normal oxygen saturation and PaO2 because of their elevated hemoglobin concentration. However, cyanosis is unlikely to occur in infants with arterial oxygen saturation above 90%. Polycythemia, with associated hyperviscosity, may interfere with pulmonary perfusion and result in persistent pulmonary hypertension. On the other hand, severe anemia can cause respiratory distress because inadequate oxygen delivery to tissues can lead to cellular hypoxia. Abnormalities of the hemoglobin molecule itself may interfere with the normal chemical combination of hemoglobin with oxygen. The most common cause is methemoglobinemia, which results from the oxidation of hemoglobin molecules from a normal ferrous to ferric state. Infants are more susceptible as fetal hemoglobin is more easily oxidized than is adult hemoglobin, and because levels of methemoglobin reductase are relatively low in infants. Methemoglobinemia may result from exposure to oxygens such as nitrites, sulfonamides, prilocaine, ethoxyplocamide, or rarely from congenital deficiency of methemoglobin reductase. The characteristic clinical scenario is a blue-gray appearing infant without respiratory distress who has decreased oxygen saturation but normal arterial oxygen tension. Whenever a newborn presents with cyanosis, especially if respiratory distress is not present, cyanotic congenital heart disease should always be considered as a potential etiology. Severe cyanosis is a prominent feature in congenital heart disease associated with diminished pulmonary blood flow or in babies with separate circulations and poor mixing. Persistent pulmonary hypertension of the newborn is a condition in which the normal circulatory transition from the fetal to newborn circulation fails to occur. In newborns with PPHN, the pulmonary vascular resistance remains abnormally elevated after birth, and right to left shunting of blood persists through the fetal circulatory channels, the ductus arteriosus and foramen ovale. This shunting leads to severe hypoxemia and cyanosis. PPHN is most frequently associated with parenchymal lung disease, including meconium aspiration syndrome, neonatal pneumonia, and respiratory distress syndrome. As a result, the majority of infants with PPHN will present with respiratory distress and cyanosis. However, idiopathic PPHN may also occur without underlying parenchymal lung disease. The goals of evaluation are to identify and provide supportive care to the critically or potentially critically ill infant, and determine the underlying cause of neonatal cyanosis so that intervention can be focused on correcting or addressing the consequences of the specific disorder. Evaluation of the cyanotic infant should systematically assess the infant for airway, pulmonary, cardiovascular, or other causes. The history may provide clues to the underlying etiology of neonatal cyanosis and should include a complete assessment of perinatal history, family risk factors, and labor and delivery. The physical examination is often central to determining the cause of cyanosis. The presence and degree of respiratory distress are important factors in delineating between a pulmonary disorder, in which respiratory distress will almost always be present, and a cardiac disorder, in which respiratory distress may not be present. However, some cardiac lesions may have a prominent component of respiratory distress, such as obstructed TAPVR and left-sided obstructive disease. Thus, its presence does not rule out congenital heart disease. The initial laboratory testing includes measurement of arterial oxygenation, complete blood count, blood glucose, blood culture, and a chest radiograph. In some cases, these studies may be sufficient to determine the underlying cause of neonatal cyanosis. Echocardiography generally differentiates between cardiac and non-cardiac causes of neonatal cyanosis. It should be performed in infants whose degree of cyanosis or hypoxemia is more severe than a pulmonary pathology would suggest. In patients who remain cyanotic despite provision of supplemental oxygen and/or positive pressure ventilation. Those who have a physical exam or radiographic evidence consistent with heart disease, or babies who present with abnormal perfusion or shock. In our center, we usually prefer to directly perform 2D echo if there is suspicion of cardiac disease or PPHN, and forego the hyperoxia test because of the potential harmful effects of 100% oxygen. As part of the physical exam, measuring oxygen saturation by pulse oximeter will confirm the presence of clinical cyanosis. It is useful to obtain both preductal, on the right hand, and postductal, for example on a foot, to determine if there is right-to-left shunting at the level of the ductus arteriosus. Differential saturations are frequently seen in infants with PPHN, as well as in some cardiac lesions, such as severe coarctation of the aorta. However, in patients with PPHN, if right-to-left shunting is predominantly through the foramen ovale rather than the ductus, pre- and postductal saturations may not be different. These cases are difficult to differentiate from cyanotic heart disease. Let's now look at the evidence for the use of pulse oximetry for early diagnosis of critical congenital heart disease. This first article, published in 2012 in The Lancet, is a systematic review and meta-analysis that assessed the accuracy of pulse oximetry for the detection of CCHDs in asymptomatic newborn babies. 552 studies published up to 2011 were reviewed, and 13 eligible studies were identified with data for over 200,000 newborn babies. The pooled sensitivity of pulse oximetry for detection of CCHD was good at 76.5%, with a 95% confidence interval of 67% to 83%. The specificity was very high at 99.9%, with an interval of 99.7 to 99.9%, with a false positive rate of 0.14%. The false positive rate was much lower when screening was done after 24 hours of life at 0.05% than when it was done before 24 hours of life, with a false positive rate of 0.5%. In a more recent meta-analysis in 2017, out of 488 relevant articles, 22 eligible articles were selected. Pooled sensitivity and specificity were similar to the previous meta, 69% and 99% respectively. The corresponding area under the curve of summary receiver operating characteristics was 0.9407, suggesting high diagnostic accuracy of pulse oximetry screening for congenital heart disease. There was, however, significant heterogeneity among the studies, which was likely due to varied use of cutoff values, diagnostic criteria, target locations, and test timing of pulse oximetry. The pooled results were shown to be robust upon sensitivity analysis. Publication bias was low based on Deek's funnel plot. The last article is an interesting systematic review and meta published in 2019. Out of 419 articles, 5 studies were selected, including 404,735 babies born after 37 weeks. The studies compared cutaneous oximetry screening and physical examination with physical examination alone. Outcomes for newborns with CCHD undiagnosed in the prenatal stage who are diagnosed early, meaning at birth in the hospital, and not late, after hospital discharge at birth. For PE alone, the pooled sensitivity was low at 53%, with an interval of 28 to 78%, and specificity was very high at 99%, with an interval of 97 to 100%. For oximetry screening in combination with PE, pooled sensitivity was reported much higher at 92%, with an interval of 87 to 95%, while Specificity was 99%, with an interval of 89 to 100%. So, some caveats in the use of pulse oximetry for screening for CCHD. Pulse oximetry screening is useful for ruling out CCHD when the result is negative. With a very high specificity, oximetry is highly useful for ruling in CCHD when the result is positive. The false positive rate may be reduced by performing screening after the 24th hour of life. Physical examination is still crucial in the evaluation of the newborn. PE alone is already highly useful for ruling in CCHD when abnormal. However, due to low sensitivity, a normal PE alone is not useful for ruling out CCHD. Normal PE combined with normal pulse oximetry screening has high sensitivity and is highly useful for ruling out critical congenital heart disease. In summary, cyanosis is a common clinical finding at birth and in the extended neonatal period. Clinicians must understand factors that affect the detection of cyanosis in the newborn. Persistent central cyanosis is always abnormal and should be evaluated and treated promptly. Neonatal cyanosis can be associated with a range of significant and potentially life-threatening diseases. For the newborn with cyanosis, the goal is to identify the critically or potentially critically ill infant and to determine the underlying cause. If indicated, call your friendly cardiologist. Lastly, it is important to understand the utility of pulse oximetry in the evaluation of the normal or sick newborn. Thank you.